So we're doing a tonsillectomy today on a 10-kilo girl that's a 1-year-old, and she is an ASA2. She has OSA. She has allergies to honey. And first, I'm going to go set up my room. So I'm going to make sure that I have my apples meds here. So my atropine, phenylephrine, propofol, lidocaine, and ephedrine and succinylcholine. I'm going to have Zofran drawn up for this patient and Decadron. So Decadron is 0.01 mg per kg, and then the Zofran is going to be 0.1 mg per kg. And then I'm going to make sure I have an oral airway that's her appropriate size. I have my taper tube in her eyes, and I have pediatric circuit on here, and I have my ventilator on pediatric settings. And then I have my ET tube that I'm going to use for her. She's going to get an oral ray. It's a size 4, and I'm going to have the half size below and above. So I'm going to have a 3.5, 4, and 4.5. And the equation for that is H plus 16 divided by 4, and then also the depth is going to be ET tube times 3. And then I'm also going to have another one leg and appropriate mask size for her. Okay, and then we also have an LMA just in case. All right, so now I'm going to do my machine check. I'm going to make sure it's plugged into the wall. My pipeline pressure is 50 psi. Check my vaporizers, that the interlock system works, and make sure that they're nice and full. These caps are tight. Make sure I can't make a hypoxic mixture. I'm going to look at my CO2 absorbent. While it's off, I'm going to do my low pressure test, and then I'm going to turn my machine on. I'm going to do my high pressure test. I'm going to close my APL valve to 70. Occlude the wide piece. O2 flush. Make sure I can maintain 30 centimeters of water pressure for at least 10 seconds. And I will be able to deliver a positive breath as well. I'm going to open my APL valve so that's ready for the case so they can spontaneously breathe. And I'm looking for my flutter valves as well, inspiratory and expiratory valves. I can do my O2 analyzer check. I want to make sure I'm suctioning the right monitoring equipment for my vitals. And then I'm going to make sure all my gases and stuff are turned off. Okay, so now I'm going to go see my patient. So I'm going to talk to the family and ask them about if they're on any medications like prescribed or other things they're taking. I'm going to ask them about their anesthesia history, if they have any family history of anesthetic problems or malignant hyperthermia or like Coca-Cola urine or something. Do they have any recent upper respiratory tract infection like cough or cold? And then I'm going to ask them what did you have for breakfast? And then I'm going to make sure they just don't have any heart, lung, kidney, GI, musculoskeletal disorders I need to know about. And then I'm going to do my patient assessment, so listen to their heart and lungs, check their mouth, assess their airway. And then I'm going to explain the procedures for my patient, first to my patient's family and the patient. I'm going to take them back to the OR, put them to sleep, make them super comfortable, put a ET tube in during the case, and then afterwards we'll extubate, take them to PACU, and then the patient's family can go and see them. So now I'm going to bring my patient back to the OR and do a mask induction. So here I have the right size mask for this patient, and I'm going to do the mask induction with the EC and SLB technique. And I'm going to make sure I don't have my fingers on any soft airway structures, only bony provinces, and it's going to cover the bridge of the nose, the cheeks, the chin, and it's going to be airtight. And since my patient is cooperative, I can do like 2 to 3% of SIBO to slowly, or just to induce them. And if they're uncooperative, I could just slam them with 8% SIBO and get them to sleep. And then I'm going to have my fresh flow gas, 7 liters on the nitrous and 3 liters on the O2. And I'm going to make sure my APL valve is fully open so they can spontaneously breathe. So they're going to be entering stage 2 of anesthesia, so that can have signs of like agitation, tachycardia, irregular respirations, dilated pupils, vomiting. They can also have obtunded airway reflexes here and uncontrolled movements. In this stage, we're really watching for laryngospasm. Laryngospasm risk can also be upper respiratory infection, secondhand smoke, GERD, light anesthetic or secretions in their airway, and then airway procedures in general, like this tonsillectomy. And then symptoms of this could be, I'm gonna notice it's hard to mask ventilate, and then if it's a complete, I won't be able to move any air. If it's partial, just like here, stridor. Complications, you can start having respiratory distress, and then you can lead to hypoxia, bradycardia, and arrest. To treat this, I'm gonna do positive pressure at 100% and remove noxious stimuli, suction out the airway. And then I can deepen my anesthetic with SIVO or probe. And then lastly, if I need it, I can use sucks 2 mg/kg. And then another airway complication is bronchospasm. The best treatment for this is actually prevention, especially in asthmatic. So I can do a NEB or bronchodilator in pre-op. And then signs of this would be difficulty masking the patient. I might hear absent breath sounds or wheezing. And then I can also get high peak pressures on my ventilator, low tidal volume, or prolonged expiratory phase, and then hypoxia. The treatment for this is 100% FiO2, deepen my anesthetic, and then I can also do 8 to 10 puffs of a short-acting beta agonist like terbutaline, or I can use steroids, glucocorticoids, or ipratropium bromide. The glucocorticoid I choose is methylprednisolone 1 mg/kg, and then the ipratropium bromide would be 0.5 milligrams every 20 minutes times 3. And then another complication during mask induction can be bradycardia, and this can be caused by succinylcholine, hypoxia, and then the pediatric patient has parasympathetic dominance innervation. So just de-ailing them or suctioning their airway can cause bradycardia. Treatment for bradycardia is atropine 0.02 mg/kg or glyco 0.01 milligrams. Okay, so now that we have masked them with our induction, they'll be getting off to sleep. So I can turn off my nitrous and then hyperoxygenate them for 3 minutes. And then I'm gonna turn my fresh gas flow down to 2, and then drop my SIVO a little bit. And then I can place the IV, give the patient their induction meds. I'm gonna dose with propofol, which is 2 to 3 mg/kg, and then fentanyl 1 to 5 mg/kg. And then I'm gonna put on all my vital monitoring equipment and tape their eyes. And then I'm gonna turn all my gases off so they're not spraying the world while I intubate them. And I'm gonna make sure that their eyes are taped as well before I intubate. And so I'm gonna grab my ET tube and my Miller 1 blade and get the tube down between the cords here, visualizing the cords. And then now that the tube is in, I'm gonna listen for bilateral breath sounds, see my chest rise and fall, and see end tidal on my monitor. And then I'm gonna tape the tube down so it's out of the way for my tonsillectomy. And then as I intubate, I'm making sure that the patient is in a neutral head position, and that if I had a hard time intubating, I could also put them in the sniffing position, and that would better align their axes. So now that I've induced and intubated, I can tape, I already said I taped the tube, but I can leave my SIVO to maintenance, which is 2.8% for this patient, and then I leave my O2 at 2 liters. So after the case, I have 2 options for extubation. I can do in a deep or an awake extubation. The deep extubation is really great because it allows for a smoother emergence, and there's no coughing, but it does leave us at risk for aspiration and unprotected airway. And then for an awake extubation, they can be coughing and moving around more, but they are obviously going to be waking up faster and getting out of PACU faster, and they have a protected airway, but they can also be at risk for spasm.